Good morning. I just want to start off by saying it's an absolute privilege for me to be here this morning with you. You are the inspiration of why we get up every day and do exactly what we do. And in the next 20 minutes or so, I also hope that I will be able to share with you some information on lung and thymic neuroendocrine tumors, which I'll refer to as NETs for the rest of the presentation. So this is the outline of the talk. We're going to spend majority of the time examining lung NETs, and we're going to try to answer the following questions. Why is studying lung NETs so important? How are they classified, diagnosed, treated, and what does a future look like? And then to conclude the talk, we'll also discuss thymic NETs, a very rare type of neuroendocrine tumor. So let's start with our first lung NET question. Why is studying lung NETs so important? And you heard this from Dr. Kuntz in the original talk, that they are not that rare. So in terms of all neuroendocrine tumors, lung NETs comprise approximately 25% of neuroendocrine tumors. And what you can see in this graph below is this is the incidence of lung NETs in that blue line. And you can see that over time, it is rising. You may be asking yourself, why is that happening? One is I think there is just increasing awareness of lung NETs. A testament is the fact that we're having this meeting today. Second is that pathologists are better at diagnosing this disease. They have better tools to do so. And finally, more recently, we actually have lung cancer screening programs. So many of the population are now undergoing imaging that wouldn't have otherwise been undergoing imaging. The second reason that it's so important to study lung NETs is that we need more evidence. At this time, we have a very low level of evidence in terms of how we treat and manage this disease. And if you look to the literature, clinical trials for lung NETs that are specific to lung NETs are very limited. So this means that our guidelines, our expert guidelines that we go to for advice are conflicting, from major neuroendocrine society guidelines to our other cancer guidelines. So we really need more evidence in this disease. And then, of course, why is it so important to study is we want to improve the care of our patients. Absolutely. This is the most important reason. So now we're going to move on to how lung NETs are classified, and Dr. Kuntz went through this in her very excellent primer this morning. Lung NETs are still classified slightly differently than neuroendocrine tumors of other regions. So it still relies on two main factors. One is what's called the mitotic index, which gives us an idea of how aggressive the tumor is. And the second is necrosis. Necrosis is just areas within a tumor that have dead cells, probably because the tumor is growing fast enough to cut off its blood supply. Ki-67 is another measurement that Dr. Kuntz mentioned. It's not as validated in lung NET, but it's definitely performed. So when we're classifying lung NETs, we want to make one basic distinction. Is this a well-differentiated lung NET, which includes low-grade typical carcinoids or intermediate-grade atypical carcinoids, or is this a poorly differentiated lung NET? And that includes small cell carcinoma or large cell neuroendocrine carcinoma. So for this talk, just because of limited time, I'm going to focus on well-differentiated lung NETs, which I will refer to lung NETs or carcinoids throughout the talk. But if there are those of you in the audience who have questions about poorly differentiated, we'll have time during the Q&A to specifically discuss that. So how are lung NETs diagnosed? So in a third of patients, these are what we call peripheral tumors. They're away from the main airway. That means essentially these tumors can go undetected for a long time because patients are asymptomatic. A lot of times these are incidentally found because patients have had imaging for other reasons, whether it's an evaluation for pneumonia or lung cancer screening. However, in 2/3 of cases, the tumor is actually much more central and within the airway. And what you can see on the radiographic figures is that when there is tumor in the airway, it can sometimes cause distant collapse of the lung. And that's oftentimes the first clue that there is a tumor sitting in the airway. And because of its location, it can cause symptoms like cough, wheezing, recurrent pneumonia, and even coughing up blood or hemoptysis. So how are lung NETs diagnosed? It's important to know that we need to accurately characterize these tumors to give you the best treatment. And it's important to know that that can take time. But that's okay because, as Dr. Kuntz mentioned, that these tumors are relatively slow growing, so we have time to accurately characterize these to create the perfect treatment plan for you. So what do we have to do to accurately characterize these tumors? First, I think you've heard it now a bunch of times, is that the classification under the microscope is critical. Second, the extent of disease or stage of disease is also very important. And for lung NETs, we use standard staging system that we use for other tumors that originate in the lung, including other types of lung cancer. We want to evaluate for a potential pre-malignant condition that is called diffuse idiopathic neuroendocrine cell hyperplasia, or DIPNEC, and we'll take a brief detour to discuss that. And then we want to evaluate whether or not the tumor is functional. So lung NETs, unlike other forms of NETs, rarely have functional syndromes, but 2 to 5% do have carcinoid syndrome, and another 1 to 6% have another secreting syndrome called Cushing's syndrome. And then we want to evaluate tumor markers like chromogranin A and neuron-specific enolase. And there is a rare inherited genetic syndrome associated with neuroendocrine tumors. It's called multiple endocrine neoplasia type 1, or MEN1, which you may hear about later today. 5% of lung NETs are associated with this genetic syndrome. So in some cases, you may be referred to for genetic testing. So what imaging is important for diagnosing a lung NET? The most important thing is CT chest with contrast. That allows us to identify any nodal metastases and also potentially any distant metastases that may have gone to liver or bone. In addition, you heard from the primer this morning that somatostatin receptor imaging is also becoming more important, including the older imaging called the Actria scan or the more newer imaging called the 68 gallium DOTA scan. There are other imaging modalities, including an MRI of the liver if we're concerned about liver metastases, or a standard PET scan that we use for other cancers, especially if the tumor looks aggressive under the microscope, that may be useful. And then even MRI of the brain. There have been reports, at least with the intermediate grade atypical carcinoids, that there can be brain metastases. So I frequently do brain imaging, at least at initial diagnosis. So we're going to go on a brief detour. I told you I would talk about this pre-malignant condition called diffuse idiopathic neuroendocrine cell hyperplasia, or DIPNEC. The thing you have to know about it is that it's extremely rare. And what it is essentially there's widespread growth of neuroendocrine cells within the airways. And the reason they're considered pre-invasive is because they don't actually invade into the airway. So that's what you're seeing in this particular image here, is that there's a neuroendocrine cell proliferation within one of the airways. And what's interesting about this disease, and about half of patients who are diagnosed, they have a very long-standing history of respiratory symptoms, cough, shortness of breath, wheezing, that can predate almost a decade. And pulmonary function tests can often show obstructions. So this pre-malignant condition is often similarly treated as we treat other obstructive lung diseases like asthma or COPD, although to be honest, there's really no standard treatment. So this diagnosis is mainly made under the microscope, but there are things within the CT scan that can suggest it. I'll just give you some buzzwords here. So there's a specific characteristic called mosaic attenuation that can be on the CT scan with this particular diagnosis. And you can see here that there's, it's sort of heterogeneous looking. There's areas that are more pure black and other areas that are more hazy that could suggest this condition. The other important thing to note is that nodules can be associated with this condition, and this is not necessarily metastatic disease, so that's very important for the physician taking care of you to know. These nodules are usually very small, less than 0.5 centimeters, and are not invasive cancers. And then oftentimes, because they're lining the airway, you can actually see on the CT scan that there's thickening of the airway. So that was my brief detour on that particular condition, and now we're going to move on to the treatment of lung nets. As I mentioned before, there's very low-level evidence in terms of how we treat and manage this cancer. So it's important that at least you seek consultation with a multidisciplinary tumor board that has some expertise in the management of this disease. And you can see in the schema that tumor board consists of many different specialists, from medical oncologists like myself, to surgeons, to pathologists, to endocrinologists, and interventional radiologists. So when we're discussing a case in the tumor board, the first thing we're asking ourselves, are there hormone-related symptoms with this new diagnosis of lung net? Because we want to treat those symptoms first. And as I mentioned, there's two main types of these syndromes. One is carcinoid, and the other is Cushing's. For carcinoid, the most common treatment is we use a somatostatin analog, such as octreotide. For Cushing's, there's other types of medical management, and in more refractory cases, even surgery of the glands that are overproducing the hormone. So that's the first thing we want to do, is to control hormone-related symptoms if they are present. The second question is whether or not this particular tumor is surgically resectable and whether the patient is fit enough to undergo surgery. If the answer is yes, then there is a straightforward path and the patient should pursue surgery. If the answer is no and the tumor is deemed unresectable or locally advanced or metastatic, there's a more nuanced plan thereafter that we will go into. But let's first start with surgery. So again, surgery is a treatment of choice because this is the only way we know how to cure this cancer at this time. So it's most important probably to consult with a surgeon who specializes in removing lung tumors, so a thoracic surgeon. You can see here on the left, the goal of surgery is to resect the tumor. And then also importantly, which is not always done, is that there should be lymph node sampling and removal. Because sometimes these cancers, as I mentioned, can go to the lymph nodes. So it's very important that the surgeon goes in and at least samples those lymph nodes. Even if there are lymph nodes involved, particularly in this region called N2, and other cancers where we call the disease unresectable for lung nets, these still could be resectable tumors. So it's very important, given the nuances of this surgery, that you seek opinion of a thoracic surgeon. What happens after surgery, that's really controversial and is really done on a case-by-case basis. This is where the guidelines really diverge. So this would be a good time to seek multidisciplinary tumor board input. So now I talked about surgery, and I want to move on to the case where you have an unresectable tumor or a tumor that has metastasized. So the first thing I want to emphasize is that active surveillance may be an option, and what I mean by that is that CT imaging is performed every 3 to 6 months to understand more about the biology of the disease. So part of our decision-making when we think about active surveillance is to look at certain factors within the tumor itself. So as I mentioned before, there are certain things like the mitotic index or Ki-67 that may give us an idea of how aggressive the tumor is. In addition, somatostatin receptor imaging, like with 68 gallium PET, may give us an idea of how aggressive the tumor is. We want to evaluate the tumor burden. Is the tumor in areas that are going to cause problems if there is ongoing tumor growth? And then, of course, are there tumor-related and or hormone-related symptoms? Because, of course, we don't want those to progress if they're present. So that's some of the things that we're thinking about when determining whether active surveillance, keeping a close eye on the tumor, is a reasonable strategy. However, if we deem that treatment is needed, what are the targets that we can go after for lung nets? So the first thing that you heard was from Dr. Kuntz was about the somatostatin receptor. So in lung nets 2, they express highly somatostatin receptor 2, so that's one way to target the tumor. The second way is inhibiting an abnormal tumor growth pathway called mTOR. And this is probably where the biggest progress has been made within lung nets with the first FDA approval of a drug. The third place is within the vasculature. These tumors tend to be very have a lot of blood vessels surrounding them. So that's another strategy by which to target that tumor. So we won't talk about that too much, but if there are questions in the Q&A, please feel free to bring them up. And then finally, I have chemotherapy in parentheses, because normally we don't really think about that as a targeted therapy, but it is still very useful, especially for tumors where we need a response or when the tumor is behaving a little bit more aggressively. So let's first talk about targeting the somatostatin receptor. What is the goal of that particular treatment? And when I refer to that, I'm talking about drugs like octreotide or lanreotide. One of them is to control hormone-related symptoms. For example, if you have a diagnosis of carcinoid syndrome. The second is to control tumor growth. So there were large phase 3 studies not done in lung nets, but in other lung nets from the GI region that were very positive, that showed that the use of these agents actually slowed the growth of the tumor. Didn't really result in responses, but halted the tumor in its tracks. And finally, I think there's been a lot of talk about this more recently, is a radio-labeled somatostatin analog, or PRRT, where you're selectively delivering radiation to the neuroendocrine cells. So this is not FDA approved yet. There was a recent exciting study published for GI nets, but that did not include lung nets. So this is one mechanism by which we can try to also target lung nets. And I just want to mention there is the first phase 3 study ever for lung nets. This is the SPINET trial, and it's examining somatostatin analog lanreotide versus placebo. And we do have that currently open at Stanford. And it's just very exciting because we don't usually have such large trials dedicated for lung nets. So now I'm going to move on to targeting the mTOR pathway. So there's an oral targeted therapy called everolimus, and this RADIANT-4 study is the study that put this drug as an FDA approval for not only lung nets but also GI nets. And they compared everolimus versus placebo, and in the study, 90 patients were included who had lung nets. There wasn't much of a response rate, but that's what we see with the majority of drugs targeted for neuroendocrine tumors. But the take-home message is that everolimus reduced the risk of progression by half. So again, it was important in stopping the tumor in its tracks. So this is another therapy that can be considered. So I do have to address chemotherapy because, again, that still remains a very important part of treatment for lung nets. There has not been dedicated trials or studies for lung nets, but there have been small series that have been reported. One common chemotherapy is called temozolomab, and what you're looking in the graph below is called a waterfall plot. So each bar represents a patient's tumor burden, and the bars that are heading downward indicate that the tumor is shrinking. So chemotherapy, although the response rates aren't as high as in some other tumors, it can definitely produce responses. So on its own, temozolomab results in response rate around 14%. But using it in combination with capecitabine can increase that response rate to around 30%. So this is a good option for tumors that need to have a reduction in tumor burden, or if the tumor is behaving more aggressively. So what does the future look like? If you read your newsfeed or watch TV, you know that immunotherapy is right now one of the most exciting classes of drugs for the treatment of other types of cancers. But we don't quite have data yet for lung nets. So where are we in terms of that? So there's one marker on the tumor that we can test for that's called PD-L1. And for other tumors, that's been a predictive biomarker of response for these newer therapies targeting PD-1 or PD-L1. And there was a recent study that was published looking at 22 lung nets where 60% of them had positive PD-L1 expression. So that may be a relevant target in lung nets. We will just have to see. There is a current clinical trial ongoing with single-agent PD-1 immunotherapy called PDR-001. And this includes all well-differentiated nets and also thoracic lung nets. So that's important to know about. So time will tell whether immunotherapy is a relevant target in this disease. So finally, I'm going to conclude my talk with thymic nets. I only have 2 slides for this, and the next 2 slides will inform you of why that is. This is the least common of all NETs. Whereas lung NETs comprise 25% of neuroendocrine tumors, thymic NETs comprise only 0.5% of all neuroendocrine tumors. The largest database we have available for these patients is in 205 patients, and that includes a European and international database. The thing to know about these tumors is that they do have a high association with MEN1 syndrome, so a patient who has thymic carcinoid or thymic NET should be referred to a genetic counselor for genetic testing. These tumors, they tend to be pretty aggressive. Half of them present as locally invasive or have some evidence of lymph node metastases. They're also associated with Cushing's syndrome, which lung NETs can also be associated with. Again, for NETs, surgery is a mainstay of treatment, and this is true also for thymic NETs. If we have an unresectable tumor or a metastatic tumor, there is really no approved or standard approach. So these types of cases should be really discussed in a tumor board that has experience either with dealing with thymic tumors or neuroendocrine tumors. So in summary, I think what we have here is progress. So there's a lot of first evers. First ever therapy approved for lung NET specifically with everolimus. That's huge progress. First ever dedicated phase 3 clinical trial for lung NET. That's the SPINET trial with lanreotide. And we need future studies dedicated to lung and thymic NET. So when I come back here next year, I can say first ever about something else. And I really appreciate you listening, and thank you for your kind attention.